Hello, my name is Anuj Patel. I'm one of the medical oncologists on the faculty of the Gastrointestinal Cancer Center at Dana-Farber. I would like to talk today about some of the more relevant topics in gastrointestinal cancers when we think about internal medicine, and specifically in relationship to the board exam. These are my disclosures. When we think about GI cancers, there are actually a broad range of diseases that are classified under this heading. These are the 5 most prevalent of those, though there are roughly 10 general types of GI cancers. The most common, colorectal cancer, falls fourth in the United States for new cases annually, behind lung, breast, and prostate cancer. However, when taken as a group, gastrointestinal cancers are responsible for the highest number of new cancer cases and the leading cause of cancer-related deaths in the United States. And while less common in the United States, gastric cancer and liver cancer are significantly more prevalent globally and are the 3rd and 4th most common causes, respectively, for cancer-related mortality worldwide. I would like to touch today on the 4 diseases with the largest body of data and evidence, and which I feel are likely to be the highest yield, specifically when thinking about the internal medicine boards. With gastric cancer, the primary form of gastric cancer seen is gastric adenocarcinoma. There have been a number of risk factors that identified that predispose patients towards developing gastric cancer. These can roughly be broken down into nutritional and environmental factors, medical comorbidities or history, and hereditary factors. Germline mutations in the E-cadherin gene are associated with a form of familial gastric cancer that is inherited in an autosomal dominant pattern. This is the only clearly identified inherited risk factor. H. pylori infection is the most consistently identified risk factor for gastric cancer. This has been associated with at least a 2-fold increase in relative risk, though some well-done studies have shown an increase in risk of up to 6 to 8 times above the general population. Based on this increased risk, H. pylori has been classified as a Class 1 carcinogen by the World Health Organization. Studies have suggested that eradication may decrease the risk associated with infection, though not necessarily back to baseline. When we break down the treatment of gastric cancer, we can break this down into patients with early stage disease, locally advanced disease, and metastatic disease. For patients with early stage tumors, surgery alone may be appropriate and potentially curative. However, for those whose disease has more advanced features, there have been improvements seen in outcomes with chemotherapy and or the addition of radiation. Adjuvant chemoradiation, that is postoperative concurrent chemotherapy and radiation, has been shown to improve outcomes. When we think about perioperative chemotherapy, there are 2 major trials that I would like to highlight. The MAGIC trial laid the foundation for perioperative chemotherapy. Patients were randomized to undergo surgery alone or to receive chemotherapy with a regimen known as ECF, epirubicin, cisplatin, 5-fluorouracil, before and after surgery. Those patients who received perioperative ECF had significantly higher progression-free and overall survival when compared to those who only had surgery. It's worth noting that 88% of patients who were randomized to the chemotherapy arm were able to undergo surgery, but only 42% of patients in that arm completed the entirety of protocol treatment. I think that this highlights both the intensity of chemotherapy used as well as the difficulty in receiving chemotherapy in the postoperative period. A more recent trial, the FLOT4 trial, looked at patients, randomized patients to receiving either ECF or an equivalent regimen ECX involving the oral fluoropyrimidine capecitabine. Randomized patients receive ECF or ECX or to receive FLOT, a regimen consisting of 5-FU, leucovorin, oxaliplatin, and docetaxel. Those patients receiving perioperative FLOT had improvements in survival compared to those receiving ECF or ECX, and this has rapidly been adopted as another standard of care. Systemic therapy for metastatic gastric cancer consists primarily of chemotherapy. There is no single standard regimen used for patients with metastatic disease. First-line chemotherapy typically consists of combination chemotherapy regimens involving a platinum agent. With first-line chemotherapy, we expect response rates between 30 to 60%, and the median overall survival for patients with metastatic disease is within 7 to 12 months. There are some biomarkers that can help guide treatment decisions for patients with advanced or metastatic disease. The first of these biomarkers is HER2, which is overexpressed or amplified in 15 to 25% of patients with gastric adenocarcinoma. For those patients with HER2 positive gastric cancer, a clear survival benefit has been seen with the addition of the monoclonal antibody trastuzumab, which targets HER2, to first-line chemotherapy. This was first demonstrated in the phase 3 TOGA trial, where patients were randomized to receive either first-line chemotherapy alone or first-line chemotherapy plus trastuzumab, and improvements were seen in overall survival and progression-free survival. While approaches are currently being studied for further HER2 therapy, there is no data currently supporting the continuation of trastuzumab or other HER2-directed therapies beyond the first line. The second predictive biomarker in gastric cancer is PD-L1. In gastric and esophageal cancers, PD-L1 expression is measured with the metric known as the combined positive score, or CPS. This differs from the tumor proportion score, or TPS, used in some other cancers, such as lung cancer. But the TPS, only positive staining in tumor cells is measured, while with CPS, PD-L1 staining on both tumor cells and certain tumor-infiltrating immune cells, namely lymphocytes and macrophages, are incorporated into the score. The role of the checkpoint inhibitor pembrolizumab in gastric cancer was first demonstrated in the KEYNOTE-59 trial. Cohort 1 of this study was a phase 2 trial of pembrolizumab in gastric cancer patients after 2 or more lines of prior systemic therapy. Objective response rate here was broken down or different between patients with PD-L1 positive tumors, that is, those tumors that had a CPS greater than or equal to 1, or PD-L1 negative tumors. In patients with PD-L1 positive tumors, the response rate was 15.5%, while in patients with PD-L1 negative tumors, the response rate was 6.4%. We can see in this waterfall plot of from this trial, which shows the best change in lesion diameters for patients receiving pembrolizumab, that patients who had a significant decrease in tumor size were primarily PD-L1 positive. Based on this trial, pembrolizumab was approved by the FDA for patients with advanced PD-L1 positive gastric or gastroesophageal junction adenocarcinoma after progression on or after 2 or more lines of systemic therapy. With esophageal cancer, there are 2 major histologies seen. Squamous cell carcinoma, which primarily arises in the upper and middle thirds of the esophagus, is the more common histology found worldwide. However, in the United States, adenocarcinoma is the more common histology, and this arises primarily in the lower third of the esophagus or in the gastroesophageal junction. There have been a number of risk factors that have been identified for both of these histologies listed here. For esophageal adenocarcinoma, the most significant risk factor is Barrett's esophagus, which is metaplasia involving replacement of healthy squamous epithelium cells within the esophagus with intestinal type cells. 1 in 7 persons in the United States will have gastroesophageal reflux disease with weekly symptoms, weekly or more symptoms. For these people with weekly GERD symptoms, the risk of developing esophageal adenocarcinoma is quite low. However, they do have a 10% annual risk per year, 10% risk per year of developing the metaplasia seen in Barrett's esophagus. And with that, there is then an annual risk of transforming to low-grade dysplasia or high-grade dysplasia. And for patients with high-grade dysplasia in the setting of Barrett's esophagus, there is an approximately 6% annual risk of developing esophageal adenocarcinoma. Below, there are a number of genetic events that have been identified at each stage of this progression. The treatment of esophageal cancer can be broken down very similarly to gastric cancer. For patients with early stage tumors, surgery alone, again, may be appropriate. For patients with locally advanced disease, however, neoadjuvant chemoradiation, preoperative concurrent chemotherapy and radiation has been shown to improve outcomes. Surgery alone is possible in the majority of patients that present with non-metastatic disease. This often involves advanced surgeries with a real risk for mortality or complications. The 2-year overall survival seen with surgery alone is less than 50%, and the 5-year overall survival is less than 25%. Multiple trials have shown improved outcomes with neoadjuvant chemoradiation with treatment prior to surgery. The landmark CROSS trial randomized patients to undergo surgery alone or to undergo surgery after neoadjuvant chemoradiation with carboplatin and paclitaxel. In this trial, a significant improvement in overall survival was seen in those patients who had neoadjuvant chemoradiation prior to surgery. When broken down by tumor histology, these improvements were seen in both patients with squamous cell carcinomas or with adenocarcinomas. However, the best outcomes were seen in those patients with squamous cell carcinoma, which is generally a more radiosensitive tumor type. Chemotherapy for metastatic esophageal cancer is similar to that used in metastatic gastric cancer. Again, no single standard regimen has been used for these patients, and first-line chemotherapy again consists primarily of platinum-based combination regimens. The outcomes in terms of response rate and overall survival are similar to those in gastric cancer. There is, however, one other outcome that is worth highlighting. A significant percentage of patients with esophageal cancer will present with dysphagia, with difficulty swallowing due to their primary tumor. In patients undergoing chemotherapy, up to 80% of patients will see relief of this dysphagia to some degree with chemotherapy, which allows for upfront chemotherapy to be an appropriate option even for symptomatic patients with metastatic disease. With patients with more advanced or complicating tumors, a localized treatment such as radiation or a procedure such as esophageal stent placement may be necessary to help further alleviate dysphagia. I would note that for patients with esophageal adenocarcinoma or gastroesophageal junction adenocarcinoma specifically, they're often treated under the same framework as that used for gastric adenocarcinoma. This includes consideration of the same biomarkers, HER2 and PD-L1. For patients with esophageal squamous cell carcinoma, however, the considerations regarding immunotherapy are slightly different. The KEYNOTE-181 trial was a phase 3 trial of pembrolizumab versus standard cytotoxic chemotherapy as second-line therapy for patients with advanced esophageal cancer. There were a broad range of patients studied under this trial, including patients with both adenocarcinoma and squamous cell carcinoma. And in the overall intention to treat population, a significant improvement was not demonstrated with pembrolizumab. However, in two subgroups, those patients whose tumor had a PD-L1 CPS greater than or equal to 10, and those patients with esophageal squamous cell carcinoma, pembrolizumab did improve overall survival significantly when compared to standard cytotoxic chemotherapy in the second-line setting. Based off of this, the FDA, this and another large trial, the FDA approved pembrolizumab for patients with advanced esophageal squamous cell carcinoma, specifically those with a PD-L1 CPS greater than or equal to 10 after progression on one or more prior line of systemic therapy. Colorectal cancer, as noted, is the most common of the gastrointestinal cancers in the United States. The epidemiology of colorectal cancer has been somewhat better studied than other GI malignancies, and a number of factors have been identified that both increase and decrease the risk of developing colorectal cancer. A number of other factors are currently being studied for which the impact is still uncertain. There are some hereditary risk factors for colorectal cancer. A handful of familial syndromes have been identified in approximately 5% of patients who develop colorectal cancer. The two most notable of these are FAP, familial adenomatous polyposis, and HNPCC, hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. These familial syndromes are associated with a significantly higher risk of developing colorectal cancer, and patients with these have different considerations regarding the intensity of screening, treatment, and surveillance. With this increased risk, considerations must also be given to different or more aggressive measures, such as total colectomy at the time of surgery. These patients, because of these considerations, clearly benefit from a discussion with a genetic counselor and or close follow-up in a genetics clinic, if possible. Even in patients without an identified inherited risk factor, however, a family history of colorectal cancer is still a significant risk factor, as is a personal history in an individual patient of prior colorectal cancer. These are associated with an approximate twofold increase in the risk of developing colorectal cancer, though the specifics of this risk increase do depend on the age of relatives at diagnosis and the number of relatives involved in that family history. An important phenomenon to recognize is the rise of colorectal cancer in younger patients. In the United States, population-wide and in most demographics, the incidence of and the mortality associated with colorectal cancer has been falling for decades. This is likely due to improved and wider adoption of different screening modalities, which allows for earlier and better identification of precancerous lesions, also likely due to improvements in surgical and chemotherapeutic treatments. However, since 1994, cases of young onset colorectal cancer, that is colorectal cancer in patients younger than 50 years old, these cases have increased by 51%. Screening is the most important factor in decreasing the risk of developing colorectal cancer. While the recommendations do vary between different bodies, the strongest recommendation from all groups is for regular screening in people between ages 50 and 75 who are at average risk for developing colorectal cancer and who have a life expectancy greater than 10 years. Individual decisions must be made in patients who are older than 75, and there is likely a limited role for any screening in patients over 85. There are two major categories of screening modalities: structural examinations such as colonoscopy, flexible sigmoidoscopy, and CT colonography allow for direct visualization of lesions. There have also been a number of stool-based tests developed. This had previously been limited to fecal occult blood testing. However, there have been advancements in immunochemical testing and in stool DNA testing. It is important to recognize that all positive tests that come from a non-colonoscopy modality should be followed up with by a colonoscopy. The specifics of staging are somewhat more important to discuss for colorectal cancer than some of the other GI cancers when thinking about the boards. Primary tumor staging, T staging, is delineated directly from the invasion of the primary tumor into the wall of the colon or the rectum. This starts with invasion into the submucosa, extending through the muscular layers into the surrounding pericolorectal tissue or the visceral peritoneum or adjacent structures. N staging, regional lymph node staging, is broken down by the number of regional lymph nodes involved. And M staging, distant metastatic staging, is simply a marker of whether metastatic disease is present. When we look at these T and M stages, stage 1 disease involves patients whose tumor has somewhat more shallow invasion, T1 or T2 tumors with no nodal or metastatic involvement. Stage 2 tumors are those with somewhat deeper invasion, T3 or T4, again, no lymph node involvement. Stage 3 disease is any lymph node involvement, regardless of T stage, no metastatic disease. And patients with stage 4 disease are those patients who have any distant metastases found. As with most cancers, survival correlates with stage at presentation. For stage 1 disease, surgery is the mainstay of treatment and highly curative. There's no role for these patients for additional treatments such as chemotherapy or radiation. On the other end of the spectrum, chemotherapy is the mainstay of treatment for patients with metastatic disease, stage 4 disease, though there is a limited role for surgery in select patients. For stage 2 and stage 3 disease, there are somewhat different frameworks for colon versus rectal cancer. In both, surgery remains the most important step in their care. In colon cancer, surgery is followed by a discussion regarding surgery, chemotherapy after surgery. However, for rectal cancer, radiation should also be incorporated at some point in treatment before or after surgery. When we think about the specifics of surgery, as noted, surgery is curative in a large percentage of patients with early disease. And fortunately, due to screening, 80% of patients will present without detectable metastases. In colon cancer, at least 12 to 14 lymph nodes should be included in the surgical specimen to be considered an adequate resection. There is increasing evidence for equivalent outcomes with laparoscopic colectomies when compared to open procedures. For rectal cancer, the location of the primary tumor does impact the type of surgery that is allowed. For higher tumors away from the anal sphincter, a low anterior resection, an LAR, may be possible that preserves sphincter function. For lower tumors closer to or involving the anal sphincter, these patients may require an APR, an abdominoperineal resection, which does result in the creation of a permanent colostomy. As noted, we need to consider radiation in patients with rectal cancer who undergo surgery, but not in those patients with colon cancer. This is directly related to the risk of local recurrence, as radiation is a local treatment. In colon cancer, the risk of local recurrence is quite low, less than 2%. However, in rectal cancer, due to the anatomy of these tumors and the specifics of surgery, the risk of local recurrence can be up to 30% with surgery alone. And because local recurrence for these lower tumors can often be associated with both significant symptoms as well as an impact on mortality, the incorporation of radiation, which can decrease the risk of local recurrence, is a critical component of the treatment of patients with locally advanced rectal cancer. Adjuvant chemotherapy has clearly demonstrated a benefit in patients with stage 3 colorectal cancer. Adjuvant 5-FU and leucovorin was shown to reduce the risk of disease recurrence by 40% and overall mortality by 33% in patients with stage 3 disease. Because of this, consensus guidelines have recommended the use of adjuvant 5-FU and leucovorin or capecitabine, an equivalent oral fluoropyrimidine, for patients who have resected stage 3 colorectal cancer. 3 trials have demonstrated further improvements with the addition of oxaliplatin, another chemotherapeutic agent, to this fluoropyrimidine backbone for patients with stage 3 disease. The largest downside with the addition of oxaliplatin is neurotoxicity, and patients do face the risk of developing longer-term peripheral neuropathy. With stage 2 disease, the data is somewhat less clear. There have been no randomized trials that had enough stage 2 patients to draw definitive recommendations. The American Society for Clinical Oncology consensus panel concluded that based on the available evidence, that the benefit for adjuvant chemotherapy for patients with stage 2 disease was somewhere between 0%, no benefit, and 5% overall reduction in absolute risk of recurrence. There may be some higher risk features, such as presentation with a T4 lesion, obstruction or perforation at diagnosis, or inadequate lymph node sampling that might impart a greater benefit from adjuvant chemotherapy for patients with stage 2 cancer. However, these have not been clearly demonstrated. There have also been a number of various gene panels that have been studied to try to delineate risk in this setting. These gene panels have been found to be prognostic. They have been shown to identify those patients with a higher risk of recurrence. They have not been shown to be predictive to identify those patients who derive a greater benefit from adjuvant chemotherapy. As such, they are generally not recommended for decision-making in this setting. Metastatic colorectal cancer is in general not a curable disease. However, patients with isolated metastases, namely those in the liver or lungs, that can be resected should be referred for surgical consideration. Up to 30% of these patients may have long-term survival or potential for cure. These patients still need chemotherapy to eliminate any micrometastatic disease that may be present, even with resection of both the primary tumor and any visible metastatic sites. In those patients where surgery is not possible, chemotherapy has still been shown to improve both cancer-related symptoms and to prolong life. And this is in a disease where the median survival without chemotherapy is approximately 6 months. This is not a slide worth memorizing. I just wanted to highlight the improvements in systemic therapy for metastatic colorectal cancer over the decades. In 1998, 5-FU was approved as the first chemotherapy option for metastatic colorectal cancer, and this was associated with an improvement in survival from 6 to 10 months. Now, in 2020, there is a broad range of systemic therapies available, as well as a number of biomarkers that have been identified that help guide treatment. And currently, the median overall survival for a patient diagnosed with metastatic colorectal cancer is over 2 years. Immunotherapy in colorectal cancer really only plays a role currently in patients with microsatellite instability high tumors. Microsatellite instability, MSI, is a hypermutable phenotype seen in tumors with impaired DNA mismatch repair function. These tumors are also known as mismatch repair deficient. MSI is detected in about 15% of all colorectal cancers. It is strongly associated with Lynch syndrome, which involves a germline mutation of these DNA mismatch repair genes. However, MSI in colorectal cancer is more commonly associated with a sporadic mutation. MSI high colorectal tumors have shown higher response rates to immunotherapy. In this landmark trial on the right, patients with mismatch repair deficient diseases, both colorectal cancer and non-colorectal cancer, as well as those with mismatch repair proficient colorectal cancer, were treated with pembrolizumab. Those patients with mismatch repair deficient diseases had a potential for significant and sustained responses to immunotherapy. However, in those patients with mismatch repair proficient colorectal cancer, the response rate to pembrolizumab was essentially zero. Based off of this trial, pembrolizumab was approved for the treatment of patients with any metastatic solid tumor identified as MSI high or mismatch repair deficient. This marked the first time that the FDA approved a cancer treatment based on a common biomarker rather than the anatomic location where the cancer originated. Pancreatic cancer is a cancer whose incidence is rising in the United States. There have, again, been a number of risk factors identified that predispose patients towards developing pancreatic ductal adenocarcinoma, including a number of hereditary risk factors. I did want to highlight one of these syndromes, hereditary breast and ovarian cancer syndrome, as the name implied, strongly associated with breast and ovarian cancer. However, mutations in BRCA1, BRCA2, and PALB2 have also been associated with an increased risk of developing pancreatic cancer. Almost 10% of pancreatic cancer patients have some inherited genetic variation or mutation that may have increased their susceptibility, and this is not always associated with a strong family history. Because of this, germline testing is recommended for any patient with confirmed pancreatic cancer, and genetic counseling is recommended for any patient who tests positive for a pathogenic mutation or patients with a strong positive family history. Treatment of pancreatic cancer is often broken down by the resectability of the primary tumor. Surgery for pancreatic tumors is often complicated by adjacent structures, namely the critical blood vessels that run through this region. Localized tumors are those that do not involve these major blood vessels, and in these patients, surgery up front may be appropriate, followed by chemotherapy. Patients with locally advanced tumors are those that do not have metastatic disease, but where the primary tumor has a degree of vascular involvement that precludes surgery. These patients are primarily treated similarly to patients with metastatic disease, though there may be some role for chemoradiation for these patients. There's a growing understanding of a category of patients with borderline resectable disease. These patients have tumor with some lesser degree of vascular involvement that might complicate upfront surgery, but that might be convertible to resectable disease with neoadjuvant therapy, with upfront chemotherapy, with or without radiation. Metastatic pancreatic ductal adenocarcinoma is treated primarily with chemotherapy, and the median overall survival for these patients is 6 to 11 months. I did want to highlight that the PARP inhibitor olaparib was recently approved as maintenance therapy for patients with germline BRCA mutations with pancreatic cancer that was treated upfront first line with a platinum-based chemotherapy regimen and whose cancer did not progress on at least 16 weeks of this treatment. This was the first biomarker-driven therapy approved for pancreatic cancer. Curative intent resection is only possible in 15% of patients who are diagnosed with pancreatic cancer, and only 15% of those patients who undergo surgery will be cured. There have been numerous trials over the last 15 years that have shown improvements in outcomes with postoperative chemotherapy, with adjuvant chemotherapy. I highlighted the PRODIGE 24 study, which randomized patients to receive gemcitabine, a prior standard of care treatment, and FOLFIRINOX, a more aggressive regimen consisting of 5-FU, leucovorin, irinotecan, and oxaliplatin. Those patients randomized to the FOLFIRINOX arm after surgery had improvements in disease-free and overall survival when compared to those receiving gemcitabine. And this has been incorporated into the standard of care. There have been studies looking at postoperative chemoradiation, and these trials have had somewhat conflicting results in terms of benefit. I did want to touch on some of the considerations for treatment of patients with GI cancers in the setting of the current COVID-19 pandemic. These patients have complicated decisions, and this decision-making must involve a discussion between patients and their providers. The risks versus benefits of treatments, specifically for palliative chemotherapy, should be considered, particularly in those patients with later line, who are undergoing later line treatment, where the potential for benefit may be lower, and for those patients at higher risk for complication, including and especially elderly patients. For certain patients, there may be a role for oral agents or treatment regimens which require less frequent in-clinic appointments to help minimize patients' exposure to the healthcare setting. And it is important to plan for pandemic restrictions that may limit the availability or alter the timing of procedures and surgery. This is especially important when trying to coordinate the timing of surgery in relationship to other treatments such as chemotherapy and radiation. With all of that in mind, I would like to go through 2 board questions. Board question 1. Your patient is a 64-year-old bus driver with metastatic gastric adenocarcinoma. Immunohistochemistry showed that her tumor was positive for HER2, 3+, and PD-L1, combined positive score 8. She was initially treated with FOLFOX, 5-FU, leucovorin, and oxaliplatin, plus trastuzumab. At the time of disease progression, she was transitioned to second-line chemotherapy with paclitaxel plus ramucirumab. Her most recent scans have, again, shown evidence of disease progression. Which of the following options is not an option appropriate consideration moving forward? A, third-line chemotherapy. B, third-line chemotherapy plus trastuzumab. C, immunotherapy with pembrolizumab. And D, best supportive care. The correct option here is B, third-line chemotherapy plus trastuzumab. This is not an appropriate option in this setting, as there is no evidence for continuing trastuzumab or any other HER2-directed therapy beyond the first line for patients with HER2-positive esophageal or gastric cancer. I would note from the question that the patient's PD-L1 CPS, which was greater than 1, is considered positive. Pembrolizumab has demonstrated a benefit in and is approved for patients with PD-L1 positive gastric or gastroesophageal junction adenocarcinomas after progression on 2 or more lines of prior systemic therapy. And I would note that best supportive care is a reasonable option for discussion at any time for a patient with cancer, but particularly in a patient with a metastatic cancer that has progressed on multiple lines of treatment. Board question 2. Your patient is a 38-year-old accountant who underwent colonoscopy after presenting with several weeks of intermittent rectal bleeding. After a malignant polyp was identified in the descending colon, the patient then underwent a laparoscopic hemicolectomy. Surgical pathology showed a 0.5 centimeter focus of well-differentiated adenocarcinoma arising within a villus adenoma. The tumor was seen to invade into the submucosa, but not into the muscularis propria. None of the 17 lymph nodes removed showed any cancer involvement. The tumor was staged PT1N0. CT imaging prior to surgery had not shown any evidence of distant metastatic disease in the chest, abdomen, or pelvis. The most appropriate next step is A, postoperative chemotherapy with capecitabine. B, postoperative chemotherapy with capecitabine plus oxaliplatin. C, postoperative immunotherapy with pembrolizumab. And D, establishing a schedule for surveillance. The correct answer here is D, establishing a schedule for surveillance. There is no evidence supporting any form of adjuvant therapy for patients with stage 1 colon or rectal cancer. The benefit for adjuvant chemotherapy has only been clearly demonstrated in patients with stage 3 disease, and there's no role for immunotherapy in the adjuvant setting for any stage of disease. I would note that the surveillance for patients with stage 1 colorectal cancer after surgery consists primarily of interval colonoscopy. These are a few references that go into detail about some of the major themes touched upon in my talk. Thank you and good luck.